Okay. All right, so today we'll talk about the admixture lesions. So here we're talking about the diagnostic set of conditions where we have increased pulmonary vascularity and cyanosis. So these are conditions where there are bidirectional shunts and also called the T lesions. And the differential diagnosis, we talked about the big three. The big three T lesions were, who's going to tell us? Transposition,
total anomalous, venous return,
and Truncus, right. Those are the big three that you want to make sure that you know something about, and we'll talk about some of these others also. We'll cover these a little bit. So there will be increased pulmonary vascularity, there will be cyanosis, but there will be bidirectional shunting. So it's the right to left shunting component of it that gives you the cyanosis, and there's the left to right shunting component that gives you the increased pulmonary blood flow. And as long as there isn't pulmonic stenosis, they will have increased pulmonary blood flow because of the decreased resistance through the pulmonary circulation whenever you have shunts that are available. So these are the most common that we talked about, and there are some less common ones also that are listed. So transposition, D-transposition, total anomalous pulmonary venous return, Truncus arteriosus. So the physiology and clinical presentation depend on the size and location of shunts. That usually would be ASDs, VSDs, and PDAs, and the absence of pulmonic stenosis. So without pulmonic stenosis, there will be preferential flow through the pulmonary circulation, hence the increased pulmonary blood flow. If there is pulmonic stenosis, then you will have decreased pulmonary circulation, and there the physiology will be more like tetralogy of Fallot, where you have cyanosis with decreased pulmonary vascularity. Cardiomegaly is usually proportional to the amount of shunting. With small shunts, there's less cardiomegaly, but cyanosis will be more severe. With large shunts, cyanosis is less severe since you're going to have more blood flow through the pulmonary circulation, but you will have cardiomegaly and increased pulmonary vascularity, more pulmonary blood flow. And there, the patient runs into the risk of developing pulmonary hypertension, arteriopathy, Eisenmenger's. And then when they start to develop Eisenmenger's, that will actually start to decrease the amount of pulmonary blood flow because the pulmonary artery pressure is increasing. And their cyanosis will also get worse because the left to right shunt converts more to a right to left shunt component there. Also, you need to know the state of the pulmonary vascular resistance in the newborn period in all conditions where there's increased pulmonary blood flow. In the newborn condition, because there's increased pulmonary vascularity, that increased pulmonary blood flow may not manifest, but then as the pulmonary vascular resistance decreases, then you get more pulmonary blood flow, and then you may start to see the changes of the increased pulmonary blood flow in those patients. So on, you're just in time to do this case. So we'll start with this case here. Now, when it comes to congenital heart disease, it helps to read the cases from the bottom up. So as we're going from the bottom up here, we want to start with identifying this guy. What is this guy?
IVC.
The IVC. Where is the IVC going to take you?
For the right atrium.
Yeah. So we want to identify the IVC because it's going to take us to the right atrium. Okay. So then this guy, let's go back here. So the IVC here is going to take you to the right atrium, right? So this chamber over here is going to be the right atrium, correct?
Yeah.
What will this guy be?
Left atrium.
Right, so that's going to be the left atrium. So once you've identified the atria, the next thing to do is to look to see what chambers that those guys connect to, right? So the IVC here is taking us to the right atrium. So what chamber is this?
Right ventricle.
Right ventricle, and this will be
Left ventricle.
left ventricle, right. So again, as we go through the heart here, we've identified the atria, we've identified the ventricles that they connect to. So, and then when we look here at the ventricle, right, between the two, we notice that there is between the right and left ventricle, did you notice anything? Okay, let's say we go through that again. So there's right ventricle, left ventricle, between them we notice there's a,
VSD.
yeah, so there's a small VSD, right? Or there's a VSD there. So the right atrium connects to the right ventricle, so there's atrioventricular concordance or discordance.
Concordance.
Concordance. And the left atrium connects to the left ventricle, so there's atrioventricular concordance there too, okay? Now the next thing to do is to identify what do the ventricles connect to? What is the outflow of the ventricles? So you follow the right ventricle here, follow it up, and tell me what it connects to.
So that's connecting to aorta.
Yeah, so this guy here, it turns out, is the aorta. You can identify the aortic arch there, okay? So the right ventricle, as we follow it up, will connect to the aorta. So you can see there's the aortic arch. You can also see the ascending aorta has the coronary arteries coming off of it. That's another way to identify the ascending aorta. It's the vessel that gives rise to the coronary arteries. So the right ventricle here connects to the aorta. So now what does the left ventricle connect to? So we'll follow the left ventricle, okay? So there's the left ventricle. So now that connects to
Pulmonary trunk.
pulmonary artery, right? And the relationship of the aorta to the pulmonary artery, is the aorta anterior or posterior to the pulmonary artery in this case?
In this case, it's anterior.
In this case, the aorta is anterior to the pulmonary artery, right? And in this case, is the aorta to the right or to the left of the pulmonary artery?
To the right.
To the right. So what do we call this condition?
So D-transposition.
Yeah, so this is D-transposition. So you have ventricular arterial discordance, right? So this is D-transposition. So here, as we follow it down, you have the aorta here coming down, going to the right ventricle. You have the pulmonary artery there going to the left ventricle, but the right atrium connects to the right, the left atrium connects to the left. So you have atrioventricular concordance with ventricular arterial discordance. The aorta is to the right, is anterior to the right of the pulmonary artery. This is D-transposition, okay? The most common cyanotic congenital heart disease in newborns is? Anybody? In the newborn period, it's D-transposition, right? The most cyanotic congenital heart disease overall is tetralogy of Fallot, but they're usually not cyanotic at birth. But at birth, the most common cyanotic congenital heart disease is D-transposition. Now, the radiographic findings associated with D-transposition, so who wants to tell me?
And on a string.
We always start with what? What do you always start with? The pulmonary vascularity, right. And so the pulmonary vascularity is increased, right. So the pulmonary vascularity is increased, the patient has cyanosis, right. There's a big heart, narrow mediastinum, we call that, as you said, this plain film sign is called egg on a string, correct, okay. The fundamental abnormality in transposition is what?
Ventricular aortic discordance.
Right, ventricular arterial discordance. That means the right ventricle is connected to the aorta, the left ventricle is connected to the pulmonary artery. On imaging studies, a very quick shortcut, if you notice the aorta is anterior and to the right of the pulmonary artery, you usually have D-transposition. So that's usually the only image you need on a test question. If you notice the aorta is anterior to the right of the pulmonary artery, that's pretty much D-transposition, okay? The normal relationship of the aorta to the pulmonary artery is?
Posterior.
Posterior
To the right.
to the right, yeah. Okay, so ventricular arterial discordance. That's what the term transposition means. Whenever you hear that term, it means ventricular arterial discordance, right? So embryologically, it occurs from failure of normal spiraling of the truncus arteriosus, so that the aorta winds up connecting to the right ventricle, pulmonary artery winds up connecting to the left ventricle. The aorta winds up anterior to the right of the pulmonary artery. So there's, with D-transposition, there's atrioventricular concordance and ventricular arterial discordance. Now this sets up two completely separate independent circulations, so it would be incompatible with life unless you have shunting that allows communication between the two. So there will always be shunting between the two communications, ASDs, most commonly VSDs, and PDAs. Otherwise, you could never get oxygenated blood into the systemic system, okay? The shunting will be bidirectional. As long as there is no pulmonic stenosis, you will have preferential shunting towards the pulmonary circulation, hence the increased pulmonary blood flow because of the less resistance, all right? So the shunts that we will have, ASDs, VSDs, PDAs, those are the various shunts that you will see in cases of D-transposition. I've also given you this diagram that shows you the relationship of the aorta and the pulmonary artery in D-transposition and L-transposition, and then in these partial forms of transposition, and also here, the normal relationship. So this is a nice shortcut. If you can identify the aorta and the pulmonary artery to tell you what the, if you have one of these more severe congenital heart diseases, what congenital heart disease you have, just by identifying where the aorta is and the pulmonary artery, okay? So the appearance varies on the radiograph on the amount of shunt and the reactivity of the pulmonary vasculature. If there is a small ASD, if there's not a lot of shunting, there will be intense cyanosis because you have two independent circulations. There, initially, the treatment is to tear open the atrial septum, that's a Rashkin septostomy, to allow communication between the two circulations, to allow some oxygenated blood to get into the arterial system, to get into the systemic circulation before they can do more definitive surgery, okay? So with small shunts, you're not going to see a lot of increased pulmonary blood flow, and there won't be cardiomegaly. Pulmonary blood flow might actually appear decreased if there's a small amount of shunting. With larger shunts, the cyanosis can be mitigated, so there will be milder cyanosis, but there will be more pulmonary blood flow, and if there's enough, that can also cause failure. And so sometimes these patients might survive to early adulthood if there are regulations, if they have something like some mild pulmonic stenosis or enough pulmonic stenosis that controls the amount of pulmonary blood flow so they don't develop Eisenmechers. So if there are large shunts, then you'll have a big heart, then you'll have increased pulmonary blood flow, and then these patients might actually develop pulmonary edema because of the large amount of blood flow going through the pulmonary circulation. It's those patients that have an intermediate amount of shunting that have the classic radiographic appearance of increased pulmonary blood flow with on a string. And as we've said, that the classic appearance may take a few weeks to manifest on the chest radiograph because you have to wait for the pulmonary vascular resistance to drop. So the ig on a string, big heart, narrow mediastinum, that's what we see as far as the plain film appearance for transposition. So we've talked about the plain film sign here of ig on a string with the narrow mediastinum associated with transposition. So the right ventricle will be connected to the aorta, the left ventricle, I'm sorry, the right, yes, so the right ventricle is connected to the aorta, as we see there, and the left ventricle will be connected to the pulmonary artery in these cases of transposition. And then you can see when both of them, the aorta will be anterior here to the pulmonary artery. You can see that nicely in the lateral view in these cases of transposition. The normal configuration, the aorta is posterior to the pulmonary artery to the right. With D-transposition, the aorta is anterior but to the right of the pulmonary artery. Okay? And we've gone through the appearance, so the aorta will be connected to the right ventricle, anterior to the right of the pulmonary artery connected to the left ventricle with D-transposition, with atrioventricular concordance. Okay, so let's talk about this case next. So here we have right ventricle, left ventricle here that's labeled. So what can we say about this? What's going on?
double outlet,
So the right ventricle is connected to what? You can see here, it's labeled, the right ventricle is connected to the aorta and the pulmonary artery. So both the aorta and the pulmonary artery are coming from the right ventricle, right? So the outflow from the left ventricle then, in these cases of double outlet right ventricle, has to be through ventricular septal defect. So with double outlet right ventricle, you will always have a ventricular septal defect, as both of these are coming off of the right ventricle. All right, so that's double outlet right ventricle. This is considered a partial form of D-transposition. There always has to be a VSD for the outflow from the left ventricle. The physiology is determined by the location of the ventricular septal defect and whether or not you have pulmonic stenosis. If there is pulmonic stenosis, then you will have decreased pulmonary blood flow and cyanosis, so that will resemble tetralogy of Fallot. And about 75% of patients with double outlet right ventricle will have pulmonic stenosis. If there is not pulmonic stenosis, then you will have increased pulmonary blood flow and cyanosis. So that's the diagnostic set that we're dealing with here, right? So double outlet right ventricle, this is what the aorta and pulmonary artery look like, and it's considered a partial form of transposition. The two major forms are type 1 and type 2. What's the difference between double outlet right ventricle type 1 and double outlet right ventricle type 2? What's the difference? Well, which one is better?
Type 1 better?
Okay, why?
Does that do like where the VSD is located?
So where's the VS? So if you think about it, you have the left ventricle, the outflow from the left ventricle is the VSD. Where would you like that to be?
Like near the aorta?
Right.
Yeah.
So that's type 1, that's the better form.
Right.
So then you're channeling the left ventricular flow through the VSD into the aorta. Type 2 is when the VSD is located subpulmonic, underneath the pulmonary artery. And then you have the left ventricular blood flow being channeled to the pulmonary artery, which is more like transposition, right? So double outlet right ventricle type 1, both the aorta and the pulmonary artery are coming off the right ventricle, but the VSD is located under the aorta. So the blood flow from the left ventricle is channeled to the aorta. That's a good thing, right? And due to that preferential flow, cyanosis tends to be mild. So clinically and radiographically, it can resemble a large VSD as long as there's no pulmonic stenosis, okay? Tends to have a wide vascular pedicle because here the aorta and the pulmonary artery are side by side. Type 2 is also called the Taussig vein complex. So here, the VSD is located underneath the pulmonary artery. So now you have a situation where the right ventricular flow is going to the aorta, left ventricular flow is channeled towards the pulmonary artery. That is transposition, right? That's bad. We don't like that. So that tends to be worse. So that resembles then D-transposition with cyanosis and overcirculation, okay? So the types of double outlet right ventricle are determined by where the VSD is located. So the most common are these two, so these two are the ones to know. Type 1, subaortic VSD, so cyanosis will be milder. Type 2, subpulmonic VSD, they will have worse cyanosis, and this will resemble more transposition, okay? Then there's an uncommitted and doubly committed form, but these two are the most common forms of double outlet right ventricle. So with type 1, the VSD is located under the aorta. The flow from the left ventricle goes through the VSD into the aorta. With type 2, the VSD is located under the pulmonary artery. So the left ventricular flow is channeled to the pulmonary artery. That's like transposition. That's not good, right? Type 3 is uncommitted. The VSD is far away from the aorta and the pulmonary artery. And type 4 is doubly committed, where the VSD can open or can allow flow to both the aorta and the pulmonary artery. But these two are the most common forms, and those are the ones that you should know, all right? So there are different physiologic variants. This all depends on whether there's pulmonic stenosis or not. The bottom line is if there's pulmonic stenosis, there will be decreased pulmonary blood flow. And so then the physiology will resemble more tetralogy of Fallot in those cases, okay? But these are the two to know, type 1 and type 2. So subaortic VSD, type 1, That physiological dilemma is more VSD, subpulmonic VSD. Type 2, that resembles more transposition, where cyanosis will tend to be worse in that condition. But both will give you increased pulmonary blood flow. Now, when you have double outlet right ventricle, there are actually two infundibuli, two outflow tracts from the right ventricle. So there's a muscular infundibulum underneath the pulmonary artery and the aorta. So you see a muscular infundibulum underneath both structures, underneath the aorta and also underneath the pulmonary artery. And again, there will always be a ventricular septal defect for the blood flow from the left ventricle to get through, to get out, okay? All right, so here's our next case. So who volunteers to take this one? Justin? So we start by identifying what? We want to find the IVC, because the IVC will take us to right atrium. So that guy's the right atrium. This guy will be this big thing in the middle. Yeah, so there's a large ASD, so we've identified that already, okay? And so now when we go through it again, right? Now we have to see, what do those chambers connect to? What does the right atrium and the right ventricle connect to? Okay, so as you go through it again, so we'll see that here's the right atrium, and it connects to this guy, which is RV, right ventricle, so this guy will be LV, and you also notice that there's a VSD there. So the next thing to do is to identify the outflow. What do the ventricles attach to? Okay. So we're going to follow the ventricles, and let's see where they take us. So there's the big VSD. So what happened? Well, is there one vessel above the VSD or two vessels? So there's your VSD, and then we go above that, and we see this guy. So what is that?
Truncus?
Yeah, so that's one vessel, that's a truncus arteriosus, and then off of that vessel you will get what? What comes off the truncus? The aorta and the pulmonary artery, right. So both ventricles then will empty into the truncus arteriosus through the VSD, that's this big guy over here. You see the coronary arteries come off there, and then the pulmonary arteries actually come off the truncus, and then here you can see the aortic arch and then the rest of the aorta, right? So this is truncus arteriosus, okay? So you can follow the aorta down, takes you to this big guy over here, which is the truncus, and then the pulmonary arteries are coming off of the truncus. So that's truncus arteriosus. Okay, so one common vessel above a VSD, both ventricles empty into that. So there's one outflow valve, that's the outflow valve to the truncus arteriosus, and then the aorta and the pulmonary artery will branch off of the truncus arteriosus. So all of your admixture, the mixing occurs over there. So embryologically from failure division of the truncus into the aorta and the pulmonary artery. So that single trunk from the heart supplies the pulmonary, systemic, and coronary circulation. There's a lot of variation in terms of the valve. It can have between 2 and 6 cusps. It will straddle a large VSD. Truncal valve is usually incompetent if it has less than 3 or greater than 3 cusps, although most commonly it is tricuspid. Also, aortic arch anomalies are common. Very common to have a right aortic arch at 30 to 40%. Also common to have an interrupted aortic arch at 20%. So it's important to remember that association with truncus arteriosus. There's an older classification of the types of truncus, they call it Edwards classification. Type 1, main pulmonary artery, comes off here, so there's a main pulmonary artery. Type 2, right and left pulmonary arteries come off from the posterior truncus. Type 3, they come off from the lateral part. Type 4, where the pulmonary arteries come off the descending thoracic aorta. This turned out was a mistake. So this is not really truncus arteriosus. That's why it's now referred to as pseudotruncus. This is actually pulmonary atresia, and these are collateral vessels. So they had to publish a retraction to their paper explaining that after they described all the variants of truncus arteriosus. So that's the Collett-Edwards classification. A better classification is the von Prague classification, where type 1 is the same as Collett-Edwards type 1, where there is a main pulmonary artery. Type 2, there is no main pulmonary artery. The right and left pulmonary arteries just come off as separate branches from the truncus. Type 3, one pulmonary artery can come off of pain ductus arteriosus. And type 4, they incorporated the fact that interrupted arch is commonly associated with truncus. So type 4 in the von Prague, there's an interruption of the aortic arch. Okay. I don't know that it's important to know all these different types, but just make sure that you can recognize when there's a truncus arteriosus, right? So you'll have the common vessel, aorta comes off of that, and then pulmonary arteries will come off of the truncus arteriosus. Increased blood flow and cyanosis, as long as there is no pulmonic stenosis. Right arch in about 30 to 40% of cases, cardiomegaly. With the type 1, when there is a main pulmonary artery, there will be a big pulmonary artery. But if there is no main pulmonary artery, if the right and left pulmonary arteries come off as separate branches, then you will not see a main pulmonary artery. Okay? And it's also common to have stenosis at the origin of the pulmonary arteries in these cases. So the plain film, increased pulmonary blood flow and right aortic arch. Here's the arch here on the MR. And then here you can see main pulmonary artery here. That's this guy coming off the truncus arteriosus. So that's type 1. Okay. Another example of a type 1. Truncus sits on top of a VSD. Aorta, in this case a right-sided arch. Pulmonary artery comes off of the truncus. In type 2 or type 3, you'll have increased pulmonary blood flow, but notice there's no main pulmonary artery here because the right and left pulmonary arteries are coming off as separate branches from the truncus arteriosus. We talked about AP window last time. The difference between AP window and truncus arteriosus, what's the major difference?
I guess you have two valves?
Yes, two valves. So with aorticopulmonary window, there are two outflow valves. There's still a separate aortic valve and a separate pulmonic valve. They're just communication of the aorta and the pulmonary artery above that. With truncus arteriosus, there's only one outflow valve, okay? And then that divides into aorta and pulmonary artery. Okay. It's a very strange case here, right? So this vessel here is what? This guy here? What am I pointing to? What is this guy? That's the aorta. It's not the arch, it's the ascending aorta, all right? This guy coming off the aorta is what? What's this guy?
Pulmonary artery?
Yeah, that's the right pulmonary artery. This guy over here is this guy.
That's the.
Yes, that's the pulmonary artery, but then you have the left pulmonary artery coming off the main pulmonary artery, but the right pulmonary artery is coming off the aorta, right? What is this called? Remember, if both pulmonary arteries were coming off the aorta, we called it truncus.
Yeah.
But if only one pulmonary artery is coming off the aorta, we call it. This is actually called hemitruncus. Hemitruncus arteriosus, right? When one pulmonary artery comes off the aorta, that's so the left pulmonary artery arises from the right ventricle here. Okay, so this also gives you a left to right shunt. Okay. Separate aorta and pulmonic valves, as opposed to truncus arteriosus. Here you still have separate aortic and pulmonic valves. but one pulmonary artery is coming off the aorta. This is called Truncus arteriosus. All right. So the right pulmonary artery here coming off the aorta. So the lung supplied by the right ventricle will have normal vasculature, but the lung supplied by the aorta will have aneurysmal dilated branches, dilated ascending aorta. This is also associated with right arch, but this is called Truncus arteriosus. All right, so here we have our next case. So this patient has increased pulmonary blood flow and cyanosis, but there's a telltale plain film finding that gives you the diagnosis. What do we have?
The snowman sign,
Yeah, we have a snowman sign. So this patient will have
total anomalous pulmonary venous return.
type,
3,
what?
type 1.
Type 1, right. Total anomalous pulmonary venous return type 1, right. So the top of the snowman is from what?
The pulmonary veins.
Yeah, so the common pulmonary vein, this vertical vein here going to the brachiocephalic vein to the superior vena cava. So that makes the head of the snowman. So total anomalous pulmonary venous return, when all of the pulmonary veins then are draining to a systemic vein instead of draining to the left atrium. So the right atrium becomes the common collecting chamber there when we have total anomalous pulmonary venous return. So these patients have to have an atrial septal defect, right, to be able to get stuff over to the left side in these cases. So this is associated with asplenia. 75% of patients with asplenia will have total anomalous pulmonary venous return. So that is an association that is worth remembering. All right. The different types, type 1 is supracardiac, type 2, cardiac, type 3, infracardiac, type 4. Yeah, right, it's any combination of these guys is type 4, right? Okay, so most of it is supracardiac, so that's the one you're going to have to be able to recognize, supracardiac total anomalous pulmonary venous return. And you do also have to recognize this one, type 3 infracardiac, right? And we'll talk about why in a few minutes. So with type 1, you'll have the pulmonary veins draining to a vertical vein that comes up here, drains to the brachiocephalic vein, to the superior vena cava, all these dilated vessels up here. That's what gives you the snowman on the plain film. That's what gives you the snowman sign. Okay? So that's type 1. There is another variant where it can drain, where the pulmonary veins can drain to the coronary sinus, and then these patients will have a dilated coronary sinus. All right? So that's cardiac, that's type 2. And then type 3 is when there's infradiaphragmatic drainage. And what's important to remember here is that this is associated with obstruction of the pulmonary venous return. So these patients will have failure with normal heart size. So because they will develop pulmonary venous hypertension, they will develop failure, pulmonary edema, but the heart size is normal. So failure, cyanosis, normal heart size in the newborn period, we think about total anomalous pulmonary venous return type 3. So it's important to remember that. Okay? If there's no obstruction, you'll have increased pulmonary blood flow, you'll have cyanosis, right-sided chamber enlargement, the snowman sign here, of course, the head of the snowman we talked about, the body of the snowman is the big heart. Okay? So there's your snowman, right? Total anomalous pulmonary venous return, type 1. So you get the snowman because of all these dilated veins here. That's what gives you the snowman on the plain film. There it is. Here it is angiographically. And then here, just drive it all home. There's your pulmonary veins, vertical vein, brachiocephalic vein, superior vena cava. That's what gives you the snowman. Here's a nice MIP showing you the snowman there. Okay? That's why you get the snowman. Now there is a type 2 can drain to the coronary sinus. That will give you a dilated coronary sinus, which will cause this impression on the barium column, but don't have a dilated coronary sinus. That's type 2. So here the pulmonary veins will be draining to a dilated coronary sinus. Big coronary sinus here. Okay? And then, if there's cyanosis with pulmonary edema and normal heart size, we think about type 3, infradiaphragmatic total anomalous pulmonary venous return. So here the pulmonary veins are draining below the diaphragm, commonly to the portal vein, And because of the increased resistance here, there's going to be obstruction. And because of that, they develop pulmonary venous hypertension and failure, but the heart size is normal. So normal heart size, cyanosis, failure, newborn period, total anomalous pulmonary venous return, type 3. Okay, normal heart size, pulmonary edema. So normal heart size, pulmonary edema, cyanosis, total anomalous pulmonary venous return, type 3. So that you want to remember. And then this is what happens. The pulmonary veins here wind up draining. So here's the pulmonary artery. Pulmonary arteries drain to the pulmonary veins here, and they wind up draining inferiorly, and they can get obstructed either by the diaphragmatic hiatus or down because of the increased resistance through the portal circulation. That also causes obstruction. Okay? So the veins draining below the diaphragm. Here's the portal vein. The obstruction occurs here. They develop pulmonary edema. Okay, so here's our next case. So this guy is left atrium, this guy is right atrium, right? But both of them are emptying into what?
The common ventricle.
Yeah, so what do we call this condition then? This is called, how many ventricles do you see? One, so what do we call it? Single ventricle, right? So it's also called a double inlet ventricle, so that's single ventricle. Now, if you look over here, this guy is the, what is this guy? What vessel is that?
Pulmonary artery?
No, it's not the pulmonary artery, it's the other one.
Oh.
That's the aorta, this is the pulmonary
Oh.
artery. So notice the aorta is to the left of the pulmonary artery, right? So most cases of single ventricle will have an L transposition where the aorta is to the left, the ascending aorta is to the left of the pulmonary artery, and we'll talk about it. So single ventricle. Most cases of single ventricle, the most common form is single ventricle of the left ventricular type. What does that mean? That this single ventricle resembles a morphologic left ventricle. So that is a morphologic left ventricle. Right? What happened to the right ventricle? It's there, but it's very small. And notice that the right ventricle, the communication here between the left ventricle and the right ventricle is this rudimentary chamber in the outflow tract, right? This is called the bulboventricular foramen. That's the communication here. And this rudimentary small right ventricle connects to the aorta. And the aorta here is to the left of the pulmonary artery. Aorta arising from the right ventricle, pulmonary artery from left ventricle, that's transposition. Here the aorta is to the left of the pulmonary artery, that's an L transposition. So these cases, most cases of single ventricle have this small rudimentary right ventricle here that takes you to the aorta and L transposition. Okay. So both AV valves connect to the single ventricle, right? But what happens is that the blood flow from the right atrium tends to go into the single ventricle and then into the pulmonary artery, which is good. That's where you want the blood flow, right, from the right atrium to go. The blood flow from the left atrium tends to be directed towards the bulboventricular foramen, right, into this infundibular chamber and then into the aorta. That's also good, right, to get your blood flow from the left atrium into the aorta. So without pulmonic stenosis, there can be mild cyanosis with increased pulmonary blood flow. With pulmonic stenosis, as in all these conditions, it will resemble tetralogy of Fallot, where you have decreased pulmonary blood flow. And that's the same with all of these admixture lesions. Right? Because you have the aorta rising to the left side, so you might have this extra density on the plain film. That's the L transposition parts. That's the aorta arising here to the left of the pulmonary artery. That's the only distinctive sign. There will be increased pulmonary blood flow and cyanosis, as in everything else in this diagnostic set, as long as you don't have pulmonic stenosis. So because of that increased pulmonary blood flow, until they can do definitive surgery, patients may require pulmonary artery banding to prevent the development of pulmonary hypertension and Eisenmengers until they can do definitive surgery in these cases. Okay? So the aorta here, rising to the left, that's the L transposition component. That might be the only distinctive plate film feature, aside from the increased pulmonary blood flow and cyanosis of single ventricle. Okay? All right, so here's our next case. So here, you can do this as a group. This takes us to
Right atrium.
right atrium. This guy over here will be,
That was the left.
that's the left atrium. So as we go through it,
Sorry.
so this guy over here is left atrium. And I've labeled this nicely for you, right? So what is that guy? LV, that's the left ventricle. So what are we looking for now?
Right ventricle.
Right ventricle. Where is it?
Here.
Did we see it?
It's really small.
It's really small. It's very small.
Right?
So, and by the way, that there's a really small right ventricle in there, right? And that connects to what? What does the right ventricle connect to? Yeah, the right ventricle connects to the aorta. So a really tiny, small right ventricle out there, right, connects to the aorta. And the left ventricle connects to, what is the left ventricle going to connect to?
Oh, it does, yeah.
Connect to pulmonary arteries. So we know this patient has this patient has a transposition. But why is the right ventricle so small? What don't we see that you want to see?
Tricuspid atresia.
Yeah, you want to look, well, look here on the left side, we can see the mitral valve, you can see the communication between the left atrium and the left ventricle. But on the right side, we don't see the tricuspid valve. So on the right side, where's the tricuspid valve? Where's the communication between the right atrium and the right ventricle? We don't see it, right? So that is tricuspid atresia. If you can't identify the tricuspid valve, there's no communication between the right atrium and the right ventricle. So where does the right atrial blood have to go? What does there have to be? An ASD, right? And there is. Right? That's tricuspid atresia. Okay? So, follow it down, you'll see that the aorta connects to the very small right ventricle right there with the arrow. No tricuspid valve. That is tricuspid atresia. So we'll play through it again just so you guys can see that. There you go. No tricuspid valve. Okay. So this is a rather complicated malformation because of the associated anomalies that can also occur. You'll have an atretic tricuspid valve. Usually the right ventricle will be small because of small amount of blood flow. There will be an intraatrial communication, ASD or PFO, but there has to be for where the blood flow from the right atrium has to get across to the left atrium. So there has to be some communication there. So the blood flow from the right atrium goes to the ASD, to the left atrium, then to the left ventricle. There's also a VSD, it has to be a VSD, and then that's how you wind up getting blood flow into the pulmonary arteries. So it's going to be an ASD and a VSD in these cases. So that's tricuspid atresia, right? So the right ventricle tends to be small. The vessel supplied by the right ventricle is usually underperfused, so that can be small too. That's why the aorta looks small in that case. Now, there may or may not be transposition in pulmonic stenosis, various combinations of this, and that's why this becomes a very complicated lesion. So the blood flow to the lungs occurs via VSD and or a PDA, right? That's the only way you can get blood into the pulmonary artery. There has to be either VSD, PDA, or both to get blood flow into the pulmonary circulation. Without pulmonic stenosis, pulmonary blood flow is increased, and you might have mild cyanosis in those cases. Now, there are various variants of this without transposition. With transposition, you can sit there and study it, and it will explain to you. You know, you can figure out what the physiologic problems are going to be. But what is the important part? There are two major forms to know. The no transposition, if there's tricuspid atresia, there's the form with no transposition. This tends to be associated with pulmonic stenosis. So these patients will have cyanosis with decreased pulmonary blood flow. That will resemble tetralogy of fluid. With transposition, there tends not to be pulmonic stenosis. And if there is transposition, notice that the left ventricle is connected to the pulmonary artery. No pulmonic stenosis. That means there's a large amount of pulmonary blood flow, large VSD, cyanosis with increased blood flow. So transposition, cyanosis with increased blood flow. No transposition, cyanosis with decreased blood flow. Those are the two variants, major variants of tricuspid atresia. Okay? So on the chest x-ray, it depends. Do you have transposition? Do you have pulmonic stenosis? So if you have tricuspid atresia with transposition but without pulmonic stenosis, then you will have increased pulmonary blood flow, flat right atrial border because of the tricuspid atresia, and then you may have a bump here, what's called the levo position of the right atrial appendage. And the right atrial appendage can be on the left side in these cases too. Right? But you don't have to worry about that. Just know the two variants of that. The important imaging finding, what we look for in imaging to recognize tricuspid atresia is what?
Atrial, small right ventricle.
There's a small right ventricle, and what else?
Large right fatty replacement.
There's fatty replacement where the tricuspid valve should be. You can't find the tricuspid valve, there's fat there, and the right coronary artery, notice the right coronary artery is displaced inward towards the atrioventricular groove because there's no tricuspid valve there. Those are the key imaging features that help you to recognize tricuspid atresia. Okay? Small right ventricle. Here's another patient with tricuspid atresia. Why is this right ventricle bigger? Yes, there's a large VSD, so that allows perfusion of the right ventricle, so that allows the right ventricle to be bigger in that case. Okay? Pulmonary circulation is increased. Patient is cyanosis, patient is cyanotic, so we're in the category of admixture lesions. The big three are
Truncus, transposition,
well, right, transposition, truncus,
total anomalous.
right? So far, so good. The answer in this case is, how do you know? The aorta is the anterior and to the right. The aorta comes off the right ventricle. Right, ventricular arterial discordance, that's transposition. D or L? D. The aorta is to the right of the pulmonary artery. This is complete transposition. This is D-transposition. All right. Cyanosis, increased blood flow. You should be able to tell me which admixture lesion just by looking at the plain film. No? No. What is this guy?
Is that the aorta?
Where's the aorta?
Oh, shoot, it's on the right.
It's on the right.
No, no, the left.
This guy is pulmonary artery, big pulmonary artery, the aorta's on the right aortic arch. What's it going to be? Which of the admixture lesions has a high association with right arch?
D-type cancer.
What? Truncus. Right. Truncus arteriosus here. Okay. Right arch, pulmonary artery coming off the truncus. Okay. Increased blood flow, cyanosis. You should tell me what it is from the plain film here, because the sign is snowman, so it's anomalous pulmonary venous return type 1. Right. So vertical vein, left brachius about vein, superior vena cava. Type 1. Increased blood flow, cyanosis.
Yeah, what he said.
What is it? Yeah, small right ventricle, tricuspid atresia, coronary artery displaced inward. There's your coronary artery displaced inward, fat replacing the tricuspid valve, tricuspid atresia. Good. Increased blood flow, cyanosis.
Double outlet.
Yeah, both pulmonary, the main pulmonary artery and the aorta are both coming off the right ventricle. So that's double outlet right ventricle. Type 2. It's a subpulmonic VSD. Is this the good kind or the bad kind? It's the bad kind. So it's type 2, double outlet right ventricle. Tausig Bing. Congratulations. You made a diagnosis of type 2 double outlet right ventricle. You can tell everybody, tell your attending, in conference, you just made a diagnosis of type 2 double outlet right ventricle, all right? So, egg on a string for D-transposition, right arch for Truncus arteriosus, snowman sign for type 1, anomalous pulmonary venous connection. Remember type 3, normal heart size failure cyanosis in the newborn period. Okay? Egg on a string for D-transposition, right? Remember that. Ventricular arterial discordance, that's what you need to remember whenever you hear the word transposition. With D-transposition, the aorta is anterior to the right of the pulmonary artery. If you just have this, that's all you need to say it's D-transposition. Truncus arteriosus, one common vessel above the ventricular septal defect. The aorta and pulmonary artery come off separately from that vessel. The snowman, you all recognize at this point, anomalous pulmonary venous return type 1. Okay? And then if you have normal heart size and failure, cyanosis in the newborn period, you want to think about anomalous pulmonary venous return type 3. Okay? Where it drains below the diaphragm to the portal vein, gets obstructed, pulmonary venous hypertension, and failure. But normal heart size. All right? So it's quiz time. Any questions?